Hello, Dr. Olson and my fellow classmates. My name is Sheeba. My clinic site is Heights Family Practice in Pearland, Texas. I had an interesting case last week, so let me start with her identifying data or subjective data. This is Miss Amelia Saxida. She is a 42-year-old Hispanic patient who came to our clinic with excessive tiredness and follow-up on her lab works. She is a reliable historian. Chief complaint is, I'm here to follow up on my lab works and the excessive tiredness. History of present illness. This is Miss Amelia. She's a 42-year-old female who came to our clinic with excessive tiredness, and also she had a lump on her sternal area almost 1.5 months ago. She denies any history of fever, cough, chest pain, short of breath, or any congestion, and also any recent travel history. She was diagnosed with brucellosis an year and a half ago when she visited her country, and she was the only one who got sick at that time. And she also complains of muscle ache, especially on bilateral lower extremities. The pain she graded as 5 out of 10, and she complains of intermittent pain. Past medical history: brucellosis in 2019, and also the surgical or surgery history or hospitalization. Hernia repair in 2010, and also she had one C-section done in 2008. Her dental and eye examination, all are up to date, and she refused her flu shot. She doesn't have no allergies or seasonal allergies or medication allergies. She is not taking any prescription drugs. She is taking her multivitamin, over-the-counter multivitamin, but no other OTC drugs. Her family history: her both parents are still alive. Dad was diagnosed with type 2 diabetic mellitus. Her mom had a history of arthritis and hypertension. Both her paternal and maternal grandparents are no more. She doesn't know the reason. She has one sister and three brothers. One brother and a sister. They both are diagnosed with diabetic. Rest of the siblings are healthy. Chemical history: she is not a smoker or doesn't expose any secondhand smoking. And drugs: no illicit, she don't use any illicit drugs. Occasionally she use alcohol or wine, and that is like 8 to 12 ounces of wine she used for the social or occasional use. Social history: she is a married woman, lives with her spouse and two kids, a 17-year-old boy and a 13-year-old girl. She owns a housekeeping company. She does have some stress related to her work, but her family is very helpful. Her hobbies: she like to cook, and also she does some artworks and stitching. Does not practice any religious practices, but she is a Catholic Christian. She minimum get 6 to 8 hours of sleep at the night time. Review system: general patient reports excessive tiredness and hasn't had any recent weight gain or weight loss. Other pertinent positive problems are gastrointestinal. She does complaints of some loss of appetite, but denies any abdominal pain and nausea, vomiting, or diarrhea or constipation. And she respiratory wise, she, even though she does have a lump, but she reports a lump in the sternal area, but denies any chest pain, any short of breath, any wheezing, any other troubles. Integumentary, also that lump nodes in the anterior chest wall. And objective data: let me start with the vitals. Temperature 97.6, pulse is 66, blood pressure 97 over 64. She runs, that's her normal blood pressure. Respiration 19, SpO2 99% on room air. Her pain is 5 out of 10, and BMI is 25.4. General appearance: she does have some mild to moderate weakness, but otherwise normal appearance. She does have normal general appearance. And pulmonary: On inspection, there is anterior chest wall nodules, the lump nodes there, where lung sounds are clear and bilaterally anterior and posterior lung sounds are clear, no bony crepitus masses or any other masses found. And musculoskeletal, she does have mild tenderness present on the bilateral lower extremities on palpation. No neck pain, no lower back pain or joint pain, normal symmetrical gait. And integumentary, on inspection, there is a 1 centimeter hard lump noted on the anterior mediastinal wall. And assessment, the 3 differential diagnoses which I included in here is brucellosis, and number 2 is COVID-19, number 3 is fibromyalgia. Brucellosis, it is an infection caused by Brucella bacterium, and usually we don't see that in US. According to CDC, there is 140 cases. Sometimes we yearly we see in US, mainly this disease condition mostly seen in South America, Middle East, Asia, Africa, and part of Mediterranean region. It is rarely spread from human to human, but mainly spread from the human to animal contact. Symptoms include chills, fever, fever comes and goes, and loss of appetite, back pain, headache, weight loss, and lethargy. The treatment is antibiotic with at least minimum of 6 weeks of antibiotic can help to treat with this disease condition. COVID-19, the reason which I included COVID-19 because it has different, each person has different symptoms of COVID-19. So she is having a lot fatigue and chronic tiredness. So that's the main reason we included the COVID-19 test. Fibromyalgia, because patient was complaining of lower bilateral muscle ache. And fibromyalgia is a chronic disease condition. There are no special diagnostic tests to rule out this condition. As a result, most of the time fibromyalgia can be misdiagnosed. Symptoms include consistent muscle pain, tiredness, weakness, fatigue, but again it is a chronic disease condition. Final diagnosis, Brucella as the priority diagnosis over the others because she does have a history of brucellosis and 1.5 years ago based on the interview and objective assessment, and also the recent lab work from the last week. It shows the Brucella IgG and IgM is positive. A diagnosis exclusion for COVID-19 when she was here last week, we did a COVID PCR test and it was negative. The rationale not to include fibromyalgia is because first of all, it's a chronic disease condition and patient does not have a consistent dull ache. Fibromyalgia, the pain is mostly there most of the time. Medication which we prescribed for this patient is doxycycline 100 mg POBID for 6 weeks with no refill, rifampicin 600 mg POQ daily for the for next 6 weeks with no refill as well. Excuse me. Alternative treatments in uncomplicated brucellosis, doxy and aminoglycosides like gentamicin combination therapy is effective. Doxycycline with cotrimexazole also is another drug of choice. Monotherapy or short-term therapy or patient is not complying with their therapy is not effective for the treatment because the relapse or the recurrence and occurrence can be more common. Follow-up, we asked the patient to come back after 6 weeks of antibiotic. Diagnostic tests which we included is history and physical, CBC, CMP, lipid panel, HbA1c because patient was complaining of chronic fatigue. That's the reason we included HbA1c, because we don't have a baseline labs on her. And vitamin D also can make patient to get chronic fatigue. So we included vitamin D level, COVID PCR to detect coronavirus, and Brucella antibody, that is IgG and IgM, with referral to agglutination. In acute brucellosis, presence of Brucella IgM and IgM within 7 days of infection, and Brucella specific IgG will be present after the second week. Both IgG and IgM will decline after a couple of months. Presence of high IgG with declining or absent of IgM signifies chronic infection or relapse. Education, we advise the patient to avoid consuming raw meat or undercooked meat and meat products. Encourage the patient to avoid consuming unpasteurized milk or milk products. Encourage the patient to wear protective gloves and glasses when handling animals or animal tissues. Instruct the patient to cover on any open wounds when coming in contacting with animals or animal tissues. Regularly wash hands. That's the main mode of transmission for any kind of infection, and strongly encourage the patient to stick on her 6 weeks of antibiotic plan. Holistic approach, that is Jean Watson's one of the criteria characters, that is a loving heart towards to the patient. So as a provider, only medical knowledge is not enough. I realized that I need to have a loving heart towards my patient to maintain a therapeutic relationship. In this scenario, I developed a sustaining, loving, interesting, caring relationship with my patient, maintained a genuine teaching, learning experiences, and caring, healing environment for all those who involved in her care. Teaching is not just the transfer of knowledge, but a heart-to-heart dialogue and connection. That is also from what Miss Watson, Jean Watson's theory. Thank you.